Hi, this is Herb Kressel, and welcome to the September Radiology Podcast. Today I'm joined by Dr. Olivio Donati of the University Hospital in Zurich. Dr. Donati is on the attending staff there, and he, with co-authors at Ghent University, Hospital Clinic of Barcelona, and Memorial Sloan Kettering, authored a very thought-provoking study on the diagnostic performance of a short dual pulse sequence prostate MR protocol compared to the standard multiparametric MRI for detecting prostate cancer. Welcome, Dr. Donati.
Thank you. Good morning.
It's very nice to have you here. So as we begin, can you tell us a little bit about prostate cancer MR imaging at your institution? How many MR exams are done for prostate cancer detection, and how many of them for staging and treatment planning would you estimate?
So at our institution, I would assume we do about 50 to 20 MRs a week. So that means about 600 to 800 a year. Most of them are for detection of prostate cancer. However, patients come with a suspicion of prostate cancer, and usually we provide also the staging information.
Okay, good. So with that as the background, tell us about the rationale for doing this study, comparing a shortened version to the more conventional multi-parametric MRI.
Well, there were several ideas behind it. First was that we had to shorten our MR slots at our institution. We still have a very comfortable length of MR slots of 35 minutes, but we were thinking of how, if we have to go down even further, could we shorten the MP MRI the most reasonably. Second, we saw an increase in exams of prostate MR over the past 1-2 years. And so, of course, in the background is also what if a screening situation might appear where MR would function as a initial test. How could we reasonably shorten the protocol without losing too much diagnostic performance?
I see.
That was one of them.
So, and tell us actually about what you did in your study. What was the basic method that you used? I know you had multiple readers from different institutions, which is quite interesting. So tell us a bit about sort of what you actually did in the study.
Mm-hmm. So we included patients, again it was 62 patients that were included, who had clinical suspicion of prostate cancer and who had standardized template biopsy within 6 months or 6 months after the MP MRI. We then had several readers, as you mentioned, in different parts of the world who looked at the MRIs. First, they were provided with only 2 sequences, the T2 transverse or axial sequences and the axial diffusion-weighted images. And they scored their suspicion for prostate cancer octant-based on a scale from 1 to 5 on a Likert scale. Then later, a month later, they received the rest of the exam, or the complete exam, consisting of all the sequences in a standard MRI, including the T1, the T2 and 3 directions, the diffusion and the DCE. And they scored again on the same scale their suspicion for prostate cancer.
And then you compared the traditional diagnostic performance standards, sensitivity, specificity, etc. So a couple of questions on the methods. I noticed that for diffusion-weighted imaging, you calculated a simulated B equals 1400 millisecond image. And why did you do that rather than obtaining one of the longer B-value images? If I remember correctly, the images were done at 3 Tesla, and you should have had quite a bit of signal to noise.
Exactly, we would have. So it would certainly be possible also to go higher than 1,400 or to 2,000. What we regularly do when we look at the images is we have a software tool where we can calculate the p-value very quick on the spot. And so it makes it very comfortable. Also, there was papers showing that there is no real difference in diagnostic accuracy, whether it's acquired or calculated. And I personally, we tried it. It doesn't give me too much of a benefit to acquire it, and it still costs a couple minutes.
I see. And the other thing that sort of was a little different than in some other studies, you decided to use 2 different definitions of, quote, clinically significant prostate cancer. Can you tell us a little bit about the 2 definitions that you chose and why you decided to look at both of them?
Mm-hmm. Well, yes, the definition of clinically significant prostate cancer, as there is no, you read different definitions. And we also wanted to show what happens if you take different definitions. So we took on the one hand the standard PI-RADS definition of any Gleason 3+4 or above tumor as clinically significant, and based on one study, for example, by Dr. Vargas and Dr. Wiener from the Memorial Sloan Kettering group, which showed that very small tumors, even with the Gleason 4 component, are difficult to see on MR. We chose a size or volume-based criteria as the other definition. Also, because we had a template biopsy as the gold standard or as a standard of reference. So we were not sure how much of the tumor we could or was sampled in the cohort. So we wanted to show both those definitions and also what happens.
Got it. So tell us, what were your key findings?
Well, what we found is that in detecting clinically significant prostate cancer by either definition, there were no substantial differences between the short protocol or the whole protocol. The accuracies, the diagnostic performance was comparable. The inter-reader agreement was comparable. So we didn't see an inferiority of the short protocol regarding diagnostic performance. That was the key findings.
Yes, I'm sure a lot of people will be very interested in that. It might make lives easier, both for the radiologists and for the patients. But I did note that with both of the definitions of clinically significant prostate cancer, there was a substantial false positive rate, and for most of the readers, it was around 50%. So, what are the clinical implications of this? Would all of these patients need to be biopsied?
Well, so we get the patients mainly before biopsy anyway, and almost all of the patients get biopsied afterwards. So even if you if you have a false positive, you will see it, or they will get biopsied anyway. But of course, maybe we were also very sensitive to not miss any cancers. That was one reason that might have caused a false positive rate. And also the gold standard, maybe a tumor was actually bigger on MR than what was caught in the template biopsy. So that would make it, of course, then a false positive, even though it might have been a bigger tumor that was not shown on biopsy. So that might be a reason for the high amount of false positives.
Well, let me flip this around a little bit. If most of the patients are getting biopsied anyway, what do you think the value of the MR is?
Well, I think it's very helpful to know where the lesion lies now that you have a lot of mainly targeted biopsies. Right. So it is certainly of help. Also for anterior tumors, I think it can be of great help to have the localization within the prostate gland.
Good. Now to kind of continue along this train of thought, in many centers, prostate MRI is performed in patients who've already had negative biopsies, but for one reason or another, there's a high clinical suspicion of prostate cancer. And so would the detection of cancer and the differentiation from post-biopsy change such as hemorrhage, would that be a problem if you just use the shortened two-pulse sequence protocol that you tested?
Well, since it doesn't include any T1, be that designated T1 or be that the DCE, the native phases of the DCE, it is possible that this would hamper the diagnostic in this stage. As I said, in our patient cohort, it didn't really matter if they were all biopsy naive or had biopsy a long time ago. But for sure, in other centers for other patient cohorts, you might want to do a T1 before to see hemorrhage.
And then what about staging and treatment planning? Would patients need to return for a second MRI exam, or are these actively supervised so that if you saw something very suspicious, you would just extend the protocol at the time?
Well, I think for staging reasons, it is very helpful, and it has been shown in the literature to have 3 planes of T2 imaging. Now, of course, if you have a very big tumor that you see already in the transverse plane, there is no need to return, in my opinion. If it would really make a difference, or if it would be really important for the treating physician to know exactly if there is a high suspicion of extracapsular extension or seminal vesicle infiltration, yes, then we could discuss to take a patient back for 2 more planes. Also, another thing that might be interesting in this topic is that we heard from the readers that it was sometimes hard with only one T2 sequence to have the zonal depiction. Is it in the peripheral zone? Is it in the transition zone? And also for this, it would certainly help to have at least one other plane.
I see. Sort of thanks. This is very, very helpful. What are sort of the next steps after completing this study? Are you doing further research, or have you made any changes? Are the slots for prostate MRI shorter now than they were?
As a matter of fact, they are a bit shorter now. I don't know if only as a consequence of this study. But my interest is also in having, since for me and also for most of readers who do prostate MR, as a diffusion is really the key sequence. We try to always optimize our diffusion sequence within a certain time range. So this is a big study interest of mine. And of course also, for example, evaluating a workflow where you would first start with the T2 and the diffusion, and then in case the diffusion has artifacts or is not adequate, to only then add a DCE, for example. So a patient-tailored protocol development of this. These are key interests.
Well, great. Well, Dr. Donati, I want to thank you and your colleagues for a very interesting study and for joining us for the podcast.
Well, thank you, Dr. Kressel.
Pleasure speaking to you.